your allocations yet? It's actually not that bad here. I think when there's no COVID, it will definitely be better. Okay. Right. Oh my. Can you all see the slides? At least you can answer the question.
I
can you see the slides? Okay. So this is just going to be a bit on like gynae cancers. I've got a few SBAs in there. And then at the end, we're going to briefly go through how you'd like do a smear test and an OSCE and kind of things you need to say. Very briefly. And I will do more OSCE stuff, but I'll probably end up doing it after my finals, sorry. Because they're in like 5 weeks now, Anish. So after that, we'll do more OSCE stuff.
Yeah, 45 days, 44 days.
Oh, you didn't need to tell me that.
Sorry.
Okay, so if you have any questions, as usual, just like jump on. It's really why is it so tiny? Anish, how do I make it bigger, the slides?
Yeah, it's like the new presenter view. You can't actually disable it. Sorry. Just make it possible.
Right, well, we'll try. Okay, so first we're going to talk about ovarian cysts. So a cyst is basically a fluid-filled sac. Can anyone tell me the different types of cysts that you can get? You can turn your mic on or just comment in the chat, because I know no one actually likes to turn their mic on. Any ideas? Yes, you can get multiloculated. You can get dermoid cysts. Physiological, yes. Can anyone think of any more groupings like that, like physiological? So follicular cyst is a type of physiological cyst. A dermoid cyst is, yes, chocolate cysts. They are, yeah. Okay, so I've grouped them into physiological cysts, which are basically cysts that develop due to an exaggerated response to normal physiological processes. So there are different types, like follicular, which is usually due to excess FSH and LH. And they represent the development of follicles, and then they commonly, so normally if you get them, usually they regress after like 2 or 3 menstrual cycles, but usually they disappear on their own, and they're the commonest type of cysts. So most cysts are follicular cysts. And you get endometriotic cysts, you can get corpus luteum cysts, which occur in the luteal phase after the corpus luteum is formed, and then you can get fecal lutein cysts, and these occur due to raised HCG or beta HCG. So these are common in molar pregnancies and normal pregnancies. So you can get those cysts when you're pregnant, but you don't want to get them outside pregnancy. Then you can get infectious cysts, so like abscesses or cystic collections of cellular debris, and these are associated with PID, so pelvic inflammatory disease. Then you get benign cysts, so these are commonly due to excessive growth of normal ovarian tissue without any type of dysplasia. So these are things like serous cystomas, which are the most common type, and then muconomas, fibromas, thecomas, and dermoid cysts, which are like teratomas, basically. Then malignant cysts, these are ovarian cancers. We're going to come on to ovarian cancers in a minute. That's why it just says ovarian cancer. And the last one is metastatic. So this is like invasion from other areas. So commonly you get endometric, colonic, or gastric cancers will spread to the ovaries. Does that make sense? So ovarian cysts, symptoms, you usually get like a dull intermittent pelvic pain, bloating, you can get early satiety, and then you can get a mass if they're big. However, a lot of cysts are asymptomatic and people don't know they've got them, and they're just picked up as an incidental finding or that kind of thing. Or like a pregnancy cyst, you might pick up at the ultrasound scans, they might notice that the patient has a cyst. So investigations, you usually do an ultrasound and it will just show a free portion of fluid in the ovarian tissue. And then management. So if you're not worried about the cyst, you'll just rescan it in 12 weeks to confirm it's gone or to confirm it's not enlarged. So like follicular cysts will regress hopefully by 12 weeks, or they should have disappeared or got smaller. But some cysts may remain for longer and you just want to make sure they're not grown. If the cyst is persistent or it's getting bigger, or you're suspicious of malignancy, so does anyone know what would make you suspicious that it could be malignant? Yes, multilobulated is, and also, so if it's multilobulated, if it's part fluid and then part solid, you'd worry. Also, if the woman is postmenopausal, you would also be slightly concerned because most of these cysts are related to most of the benign cysts are related to estrogen levels, and like LH and FSH, in which case you wouldn't expect a postmenopausal woman to have the cysts occurring. So you can get cyst torsion and rupture. So does anyone know what these two different things are, or does anyone know why torsion particularly is an emergency? Yeah, so you can lose your ovary because it cuts off the blood supply. So the symptoms are sudden onset, severe unilateral pain. You can get nausea, vomiting, tachycardia, and hypertension. These are like symptoms of being systemically unwell, basically. And then investigation. So in torsion, you will see free fluid and the whirlpool sign, and you'll also get an enlarged ovary because it's engorged due to edema. And then in rupture, you can get free fluid. So torsion is an emergency because you can get irreversible ischemia of the ovary in 72 hours. So you need to like do something quickly to stop this happening. And does anyone know what type of cyst most commonly leads to torsion? It's a bit of a niche question. So it is a dermoid cyst or a teratoma, which is why so torsion is more common in younger people because those types of cysts are more common in younger people. In terms of management, you want to do like your Dr. ABCD and analgesia if the woman is unstable. And then with torsion, you need to do an urgent laparoscopic ovarian cystectomy. So you basically take out the cyst and then untwist it and untwist the ovary. However, if you got there too late and the ovary is already necrotic, you just remove the ovary because otherwise it's going to die and then it could become cancerous. Rupture is just self-limiting because there's nothing you need to do about it. Because usually it's only a really small amount of fluid, so there's nothing, you don't need to like open them up and wash them out or anything like that. However, if they're recurrent, you can start women on the pill because this will stop them ovulating, and then because most cysts, as we said, are follicular, so it will stop them ovulating. If it's just like they're getting recurrent follicular cyst ruptures, you can put them on the pill to stop them ovulating, and then they won't get any cysts. Does that make sense? So for rupture, you just don't do anything. Unless, so basically, because the rupture is only a small amount of fluid, there's nothing you really need to do. You just need to make sure the woman is stable and make sure there is no torsion or anything going on. But because the cysts are normally really small, and it's just a small amount of fluid that leaks into the cavity, and there's nothing else that goes into the like into your peritoneum, you don't need to do anything. But if what I was saying is if they get lots of ruptured cysts, because most cysts are follicular, you can start them on the pill so they don't ovulate. And if they're not ovulating, they're not going to produce the follicles and they're not going to get the cysts. Does that bit make sense? But in the if they just had one, you wouldn't do anything. You just check the woman stable. Okay. Let me know if anyone's got any more questions. Right. Ovarian cancer. So there are three main different types of ovarian cancer. The first type is epithelial tumours, which are most common, and these make up like 90%, as I said, of the ovarian cancers. And basically, this is just like malignant transformation of the ovarian capsule epithelium. So it's thought to be due to irritation of the epithelial lining, basically during ovulation. And they usually develop in women over the age of 60, so they're normally a postmenopausal cancer. And there are different types. So serous is the most common. Mucinous is an estrogen-secreting tumour. Endometrioid and clear cell cancers are both rarer, but they have, if you have endometriosis, it's a risk factor for getting those two types of cancer, but they're not very common. The most common is the serous type. Then there is germ cell tumours, which are rare. They account for about 4% of the tumours, and they are basically derived from undifferentiated pyramidal germ cells of the ovaries. They usually develop in adolescents and women under 40, so they're very uncommon. But if you have a younger person with ovarian cancer, this is what it's likely to be. So you can get immature teratomas, which are usually benign and cystic, and they can contain bits of like hair and bone and that kind of thing. And these are the most common benign tumours in people under the age of 30. Then you can get desmorphin tumours, which are the equivalent to a testicular seminoma. And then you can get endometrial sinus tumours, or like yolk sac tumours, which you might have heard of because you can get yolk sac tumours in like the testes. And then the chorangioma, which secretes beta-HCG. And the last type is the sex-cord stromal tumours, which are also quite rare. And these are derived of the stroma of the gonads, so they're cells that produce estrogen and progesterone. So these are usually benign, but because they produce estrogen and progesterone, you can get consequences of them secreting estrogen. So they can cause like bleeding between your periods. They can also cause endometrial hyperplasia, which is therefore a risk factor for endometrial cancer. And they can also secrete androgen, so you can get like breast atrophy, hirsutism, and deepened voice. So they usually occur between the ages of 40 and 60. And then the different types, so you get the granuloma cell tumour, which secretes estrogen, then the thecoma, which also secretes estrogen, then the ceratoleuctic tumour, which secretes androgens, and then the fibromas. And these don't secrete any hormones. But if anyone's heard of Meigs syndrome, or has anyone heard of Meigs syndrome? Does anyone know what Meigs syndrome is? Yes, so Meigs syndrome is basically you get a benign ovarian tumour plus ascites plus pleural effusion, and the ovarian tumour is usually a fibroma. So basically Meigs syndrome is where you have a fibroma, you have pleural effusion and ascites all together. Does that make sense? It's a bit niche, and I probably don't think you need to know it, but it's just something to be aware of. So the risk factors for endometrial cancer are increasing. Sorry, I'm having to read the questions. So serous cysts, they're unrelated. They're basically it's just a cyst which is out of the same tissue as a cystadenoma. So they're unrelated, but they're just out of this. They're made from the same serous epithelium, basically the same like original cells. Does that make sense, Lizzie? I don't actually know what the difference between mature and immature teratomas are. Anish, do you know? I feel like Anisha's gone. I'll look at that in a second. So in terms of risk factors, can anyone think of any risk factors? For ovarian cancer? Okay, so the risk factors include increasing age, so obviously postmenopausal, most of them occur in older women. Having no children, and the reason for that is, if I remember earlier and I said endometrial tumours are caused by like more irritation. So more, if you have no children, you have more ovulation, which also means that if you, like Claudia said, if you have late menopause and early menarche, you've got more cycles, so you have more irritation of the lining. Obesity is also a risk factor, and that's just to do with the fact you have increased estrogen from obesity. Having family history, and then BRCA mutations. So BRCA1 and 2 is a risk for breast and ovarian cancer. So the risk for ovarian cancer is less than breast, but it is still a risk. And can anyone think of another genetic condition which is also a risk factor for? It's a risk factor for ovarian and also endometrial cancer. Can anyone think of what that is? Yep. So Lynch syndrome, or hereditary non-polypous colorectal cancer, because you basically get polyps. You get loads of polyps in the colon, but you can also get polyps in other places. So you can get polyps in the ovaries, and then in the endometrium as well. So that is a risk factor for both ovarian and endometrial cancer, as well as colon cancer. Okay, next slide. So the symptoms, it's important to note that the symptoms of ovarian cancer are very, very non-specific and vague. So it's often diagnosed quite late in in women. So people are often diagnosed at late stages, and therefore the prognosis of ovarian cancer is not actually very good, just because it's not identified early on. So it can be asymptomatic, and for most people it is, and they don't pick it up till they have signs of METS, for example, or they've got severe disease in their abdomen, or it's picked up incidentally. So you get abdominal bloating, distension, and discomfort. You get weight loss and early satiety, and that's just from like the tumour pushing up on your stomach and things. Fatigue, urinary frequency, pelvic pain, pressure, and lower back pain, and that's again just from the tumour effect. And then on a bimanual exam, you might feel the adnexal tenderness and the mass. Okay, so I haven't set up Venti because I only had a few SBAs, but if you had a 58-year-old woman who has presented with a 3-month history of bloating and decreased appetite, she has no history of altered bowel habits, on examination a palpable mass is felt in the suprapubic region, consequently a FIT test is done and it comes back negative, what's the next most appropriate step? So if you have a quick think, and then in a second I will get people to write in the chat what they think their answer is. Okay, does anyone want to hazard a guess at what they think the answer might be? Any ideas? Someone's going for 4. Anyone else? Two. Okay, so in this situation, what you would do is, so there's one other thing here is these kind of symptoms, so like bloating, decreased appetite, can be signs of bowel cancer. So that's another thing is lots of these women will be investigated for bowel cancer first, and then they be referred down the gynae route. So because the FIT test here is negative and there's no history of altered bowel habits, so you're thinking that like colon cancer is probably very unlikely. So the important things to note are that she's got a palpable mass and she's got bloating and decreased appetite, so she could have signs of ovarian cancer. So the correct answer is refer to gynae under a 2-week wait. So yeah, what you would do is refer under the 2-week wait. You could take the blood tests and do that, and then give it to her to take to the referral, but she'll probably have the blood tests done in clinic and get her results then and there. And this is basically due to the guidelines. So for the investigations, if there is a woman is coming in and you think she might have cancer and there's no mass, so you've examined her, there's no mass, the first thing you look for is tumour markers. So the first one you would do is like the CA125, which is greatly raised, it indicates cancer. And if it's raised, then you would do an ultrasound. But you've got to be careful because it can also be raised in if the lady is menstruating, if she's got endometriosis, if she's got PID, if she's got any ovarian cyst. It can be raised in pregnancy. It can also be raised in perineal trauma. And then heart failure, so that's a one to bear in mind. And then also other cancers can raise it. So if you've got lung cancer or peritoneal cancer or pancreatic cancer, they can also cause raised CA125s. And then other markers you might look for are beta HCG, which can be raised in germ cell tumours, and then alpha fetoprotein, which is the AFP one, and that is raised in germ cell tumours as well. And then the CA199, which is raised in mucous epithelial tumours, and then inhibin, which can be raised in granulomatous tumours. So once you've done the tumour markers, if they have a raised CA125, you then will do an ultrasound, and this will show like a mass that basically looks suspicious. So it will show a solid mass, a complex mass, sepulated mass, multilocated mass, something with high blood flow that looks suspicious, and then you refer under the 2-week wait referral. However, if you find a palpable abdominal pelvic mass, or they have ascites on ultrasound, on examination, you bypass the ultrasound and the CA125, and you refer straight away under the 2-week wait. So does that make sense to everyone? Are there any questions about that? No, does that make sense? So you do what? So basically, the ultrasound, you'd probably do a transvaginal and a pelvic, unless the woman didn't want a transvaginal, in which case you'd just do a pelvic. Does that make sense? But normally you do both. So if you refer a woman for a transvaginal ultrasound, they always get a pelvic one, so like an onto the skin one before they get the transvaginal one. Does that make sense? The ultrasound isn't necessarily done in gynae clinic. You can book them, so like you can be referred for an ultrasound of an ultrasound of anything in a standalone clinic that you can be referred for that. So it doesn't have to be in a gynae clinic. You do that, and then if that came back looking suspicious, then you would refer under the 2-week referral. So yeah, the CA125 is raised. You arrange a transvaginal ultrasound, and it will be transvaginal ultrasound and a pelvic one. As I said, they're done together. Okay, have I answered everyone's questions? Lizzie and Francesca, have I answered your questions? So you would do both. I'll keep going. If I haven't answered them, let me know. Okay, so basically the pathology, well, usually basically it looks like a cluster of abnormal cells, and you have dyschorotic nuclei, but it's important to note that quite often with ovarian cancers, and it's the same with testicular cancers, you don't take a biopsy and then leave it. You normally take a sample when the whole tumour's been removed. So normally what you do is you think it looks like ovarian cancer and you will remove the whole mass, and then you'll send that for histology. And that's just because of where the organ is located and because of the supply of the tissues and everything around it, it's likely that if you go in and take a biopsy, you can disseminate the tumour. So in testicular cancers, if you take a biopsy of the cancer, because you're going through the skin, and it's likely that you can spread the cancer to the skin and also to the lymph nodes more easily. So usually what you do is you remove the whole testy and then you take a sample of that and look at histology. So the same with ovarian cancers. You don't usually take a biopsy. You usually take the whole tumour out and then you take a sample for biopsy. Does that make sense too? And then for gynae cancers, they use a staging called FIG staging. So this is the same for all gynae cancers. So I'll go through it once and then you kind of edit it according to the cancer. So stage 0 is a carcinoma in situ. Stage 1 is where it's confined to the ovaries. So in cervical cancer, stage 1 is where it's confined to the cervix. Stage 2 is invasion of the surrounding organs or tissues within the pelvis. So for example, in ovarian cancer, it could have invaded the uterus. And then stage 3 is spread to distant nodes or tissues within the abdomen. So in stage 3, it could spread to the bladder and the bowel, for example. And then stage 4 is distant mets, so like lung mets. Does that staging make sense? So it's worth kind of going over it, just because if you know the principles of the staging, that's what's used for all the different gynae cancers. And you just kind of edit it according to what cancer it is. So it's confined to the ovaries if it's ovarian, or confined to the uterus if it's endometrial cancer. The stage 1. Okay, so the management, ovarian cancer. So early stages, you do surgical removal. This is very extensive. So you do peritoneal washout firstly, then you do a total hysterectomy, then you remove both fallopian tubes and the ovaries, then you remove any omentum of the area. You also remove the appendix, just because that's sort of nearby, and then you move the pelvic and para-aortic lymph nodes as well. So it's a huge surgery, and basically you take everything out of the pelvis, and then you can give chemotherapy afterwards. But it's important to note that most women are diagnosed in late stages, so most women will undergo just chemotherapy, and that's because the tumour is already disseminated, so there's no point operating and taking out all of their ovaries and everything, because it's already spread. Okay, anyone got any questions on that? And back to that earlier question, so a mature teratoma is benign, whereas an immature one is malignant, basically. I don't know any more detail than that. Maybe unusual, although I feel like he's gone. Oh dear.
I'm still here. What was the question?
Oh, what's the difference between a mature and an immature teratoma?
Gynae is not my forte, but I'll have a Google.
I don't think you need to know that. You just need to say teratomas are quite common tumours, and they basically just contain like human cells, basically. Like they get skin and hair in, and they're more common in younger people. And they are the most common type of cyst to cause torsion, which is why torsion is more common in younger people. From a gynae perspective, that's all you need to know. Okay, so next.
Wait, so apparently mature ones are benign and immature ones are malignant. But I've just learned that, so I doubt that's coming up in exams. But if you're interested in gynae, have a read.
I'm sorry, we can't help you, Francesco, but I don't think it's that important. So hopefully it's fine. Okay, so endometrial cancer. There are like 3 different kind of phases to this. So you have pre-malignant disease, which is basically when you just have hyperplasia with atypia. What's atypia? So atypia is basically when you just have like atypia is basically when the cells aren't typical, so there's something different about them, they're abnormal. And this is usually caused by, so the pre-malignant stage is usually caused by chronic estrogen exposure, which is unopposed by progesterone. And that basically leads to endometrial hyperplasia. And if you get hyperplasia of the cells, they're more likely to mutate and become abnormal. So basically, then you can get further stimulation predisposes to abnormalities in the architecture, and that's when you get atypical hyperplasia. So just normal hyperplasia is when you get proliferation of the endometrial glands resulting in greater gland-to-stroma ratio than normal, and then something else will happen. So you get like another, they just mutate, they just continue to divide, and then you get mutations, and these mutations can then lead to them becoming cancerous, which is the next step. And about 25 to 50% of the pre-malignant disease will actually become endometrial cancer. So type 1, which is the most common type, and this is estrogen dependent, and this arises from the atypical endometrial hyperplasia we just talked about. And it's basically due to excess estrogen. So 90% of the tumours are adenocarcinomas, which are endometrial secretory or mucosan. So they're similar type to ovarian, they're like named the similar thing. And then this affects both premenopausal, menopausal, and postmenopausal women. And then type 2 is just the 20%. So these are non-endometrioid, and these are not estrogen dependent. So they do not arise from endometrial hyperplasia with atypia. And because of that, they're consequently more aggressive. So these are like serous carcinoma, papillary carcinoma, clear cell carcinoma, undifferentiated carcinoma, and then carcinosarcoma. And these typically affect elder women who have endometrial atrophy. So the most common one and the one you need to worry about is the type 1 ones, which arise due to endometrial hyperplasia. So risk factors, and these are all risk factors for type 1, so the estrogen dependent, are increasing age. In fact, before I do any more, can anyone think of any risk factors? Obesity. Why is obesity a risk factor? Sabrina, yeah. Estrogen exposure, HRT, yeah. PCOS. Okay, so increasing age, family history of endometrial cancer, endometrial hyperplasia, as I said before, then unopposed estrogen. So this is the things that you guys have just come up with. So endogenous causes are like early menarche and late menopause, having no children, PCOS, obesity, and diabetes. So in obesity, it's because the adipose cells can secrete estrogen. In PCOS, it's because you're not ovulating, so you can get excess estrogen. And then exogenous causes are like having estrogen-only HRT, and then tamoxifen. And then Lynch disease, so as I said earlier, the hereditary non-polypus, sorry. Hereditary non-polypus, is it colon, what was it called? Hereditary non-polypus colorectal cancer causes polyps and that kind of thing, and it causes them everywhere, and that's also a risk factor for ovarian and endometrial cancer. And the last one is pelvic irradiation. So having been treated for like another type of cancer, had like irradiation of the pelvis can then lead to a higher chance of getting endometrial cancer. And it's, so endometrial cancers, investigations and symptoms. So the symptoms are most commonly postmenopausal bleeding. So because endometrial cancers most commonly occurs in women after menopause, the most common symptom is postmenopausal bleeding. So if you're in GP and you see anyone with postmenopausal bleeding, they immediately get like a 2-week wait referral to gynae. So that is a common thing. Also, Claudia, you said combined oral contraceptive use, so that is a risk factor. But I think by like 5 years after being on the pill, your risk factor goes back down to normal baseline. Does that make sense? It's the same with, because it increases the risk of another type of cancer. No, combined oral contraceptive pill is protective against the breast cancer and cervical cancer. The combined pill is a risk factor for. However, after like 5 years of being on the pill, your risk factor goes back to baseline. 5 years being off the pill, sorry, goes back to baseline. Sorry, back to symptoms. So postmenopausal bleeding. So any woman with postmenopausal bleeding. So this could be like a history you have to take in an OSCE or just an SBA question. But anyone with postmenopausal bleeding, you refer straight to the 2-week wait referral. And then if you're premenopausal, you could have like irregular periods, or you could have like bleeding between your periods. And you can get an abnormal vaginal discharge, but it's not as common. And then if you do a bimanual, the uterus might feel bulky and fixed, and you could feel a mass. Does anyone know? So if you start a woman on HRT, sometimes they can get bleeding because you've started on HRT. How long should you wait for the bleeding to stop? And at what point should you refer them to a gynae clinic for a 2-week wait? Does anyone know? Okay, so after 4 months, so because HRT can cause bleeding, by about 4 months, the bleeding should have settled down and stopped. But if they're still bleeding after 4 months, you should consider that this is postmenopausal bleeding and you need to refer them to the gynae clinic under the 2-week wait for possible endometrial cancer. That's important to note. Okay, and then investigations. You can do a transvaginal ultrasound. And basically you do this and you measure the thickness of the endometrium. So if it's more than 5 millimeters, it's likely that they have cancer. So you need to do a hysteroscopy and a biopsy. If it's less, cancer is very unlikely, and so you don't need to do any investigations. So basically you do the endometrial biopsy and histology is taken, and you use a Propel suction curate, and basically you find abnormal cells, and you can do this by hysteroscopy. So if, for example, you do the ultrasound and the whole like uterus is all like 6 millimeters, then you can just biopsy any of it. But if you do it and there's only like one specific area that's over 6 millimeters, then you would do the hysteroscopy at the same time, so you can make sure you can see which area to do it in, and then take the biopsy from that area. But if it's like globally, then you can just take it from anywhere. And then the same thing again, it's staged using the FIG staging. So I'm not going to go through that again unless anyone really wants me to. But you can Google it and it's online, but it's the same principle. Basically, it's 5 stages, stage 5 being, or 4 being distant mets, and stage 0 being a carcinoma in situ. So the management. So stage 1 and 2, you do a total hysterectomy and bilateral ovaries and fallopian tube removal, and then you take away the lymph nodes. And then if the woman is wanting fertility preservation is wanted, so that means she's like obviously not postmenopausal and she's younger, you can give them progestin therapy, which is basically progesterone, and then you'll do 6 monthly biopsies. So you leave the uterus in. At this point, the cancer only target is only a small part of the uterus. So you basically leave the uterus in and keep biopsying it to check it hasn't spread and hasn't gone anywhere. Obviously, most oncologists would not advise this, but if the woman really wants to try and get pregnant, that's what you would do. And then stage 3 and 4, you do a total hysterectomy, bilateral fallopian tube and ovary removal, and then you can also do radiotherapy and chemotherapy. Because it's higher stage, that is what you would do. And then all non-endometrioid tumours are treated like as stage 3 or 4. So that second type I said, type 2, which are non-estrogen dependent, they're all treated as stage 3 or 4. And then if it's recurrent or incurable, you would do palliative care, so chemo and radiation. And these tumours can be estrogen or progesterone receptor positive, so you can treat them with progestin or aromatase inhibitors like you would treat breast cancer, but obviously you don't give tamoxifen, because tamoxifen is given in premenopausal women, but it can increase the risk of endometrial hyperplasia. Any questions about that? So we're going to go on to the next bit now. Okay, so we have an SBA. So a 26-year-old female presented with a 2-month history of post-coital bleeding. She has no intermedullary bleeding, no menorrhagia, and no vaginal discharge. Her periods are regular. She has recently started the combined oral contraceptive pill. She has been with her boyfriend for 2 years and has had no other partners. Her first smear test was 6 months ago and it was HPV negative. What would be the next most appropriate step? So firstly, you need to try and diagnose her and then think about what you do next. Okay, if anyone's got any ideas, feel free to put them in the chat. Any suggestions? Okay, so she's got post-coital bleeding. She's recently started on the pill and she has a negative HPV. And the HPV is negative. So what you'd actually do is stop the combined oral contraceptive pill. So it's likely that she has an ectropion, as you said, Francesco. So she's got no discharge, and most so as number 4, which people have mentioned, would present with discharge usually. It's uncommon to present with post-coital bleeding. You usually get like pain and discharge, and you can, in some cases, get post-coital bleeding, but it's a very uncommon symptom. So the fact that she's recently started on the combined oral contraceptive pill, and the fact she's has a regular partner makes it more likely that she's got an ectropion. So you would switch it, you'd stop it and switch to something else. So yes, the proper answer I should have put was stop the combined oral contraceptive pill and start her on like a progesterone only pill. So you would stop it and switch her to a different type of contraception. So an ectropion, does that make sense to everyone? I'm going to go through what an ectropion is in case you don't know. But yes, you're right, you would stop the pill and switch her onto a different pill. But if the symptom was concerning her, she should stop the pill. So basically an ectropion so you have the exocervix, which is the outside of the cervix, and that is lined with stratified squamous epithelium. And then you have the endocervix, which is the cervical canal, and that's lined with columnar epithelium. And then where the two exocervix and the endocervix meet is called the squamous columnar junction. And if you can see my tiny little picture, I hope it's not that tiny for you, it's really tiny for me. And basically an ectropion is a version of this junction. So usually it meets like this, and what happens is the ectocervix basically, the endocervix, which is normally inside, comes out basically over the outside, and these cells are more delicate, so basically they can bleed. So what happens is the junction's usually here, and basically the junction just moves so that the cells that are usually inside are now outside. And it's effectively due to estrogen. So elevated estrogen results in a larger area of the columnar epithelium being present on the ectocervix. So they appear usually during puberty, during pregnancy, or when you start the combined oral contraceptive pill, and they usually resolve postmenopausally. So it's actually common that most women, a lot of women will have them, but they don't bleed in everyone. So did my diagram and hand movements make sense to everyone? Because it took me a long time to figure out what this was. So in this case, because she's got an ectropion, and as I said, they're estrogen dependent, you would stop her combined oral contraceptive pill, and as Leanna said, you would switch her to something else. So you could start her on a coil, a progesterone only pill, an implant, or something else, basically. Or you could try a different pill with a lower amount of estrogen, because I don't know if you know that the pills have different amount of estrogen and progesterone. So you could try a different pill with a lower amount of estrogen and hope that that resolved the ectropion if she wanted to stay on like a combined pill. Any questions? So most of the time they're asymptomatic and they're usually found incidentally on a speculum. And then you can get intermedullary bleeding and bleeding after sex, but bleeding after sex is most common, like the way they present. And then you can also get discharge, but that's also very uncommon. So most of the time you just get the postcoital bleeding. So you can investigate by doing a speculum. And basically it's like a red area is that you see, and it might bleed when you do the speculum, like if you knock the ectropion when you're doing the speculum, that it could bleed. And it's just like a bright red area. So the speculum gives you like a pinky colour and it just appears much redder. And then you can do a smear test to rule out cancer. In this lady, she had a smear test 6 months ago, which was HPV negative, so it's unlikely she's developed cancer in that time. And then management, so if they're asymptomatic, you don't need to do anything. Or if the woman's fine with, like, isn't the bleeding's not that troublesome and now she knows what it is, she's fine with it, you can keep her on the pill if that's what she's on. But otherwise you can stop the pill. And if they want the ectropion removed, so for example, if it's not resolving when they stop the pill, you can take it, you can like move it, like so burn it off with silver nitrate, or you can like cut it out basically. But they're very harmless things. They will resolve postmenopausally. Any questions about that? Okay, the last bit now is on cervical cancer and cervical interepithelial neoplasm. So this is basically abnormal cells confined to the epithelium of the cervix, and it is caused by high-risk HPV. So this is normally 16 and 18, but also 31, 33, and 45 can also cause CIN. And it's spread through sexual activity through skin-to-skin contact. So basically what happens is infection with infection with human papillomavirus, which is what HPV is usually transient, and you don't get any, like, they have no symptoms of it, you usually have it and then your body clears it. But in a minority of people, they can't clear the infection and it just persists in the genitals. And then basically the human papillomavirus DNA becomes like integrated into the basal cell epithelium DNA, and it triggers like oncogenetic changes. And then the cells become immortal, basically, and you get rapid turnover of cells, and that's when you get the cervical interepithelial neoplasia. And then these cells have like an abnormally large nucleus, and they have minimal cytoplasm, and they've got lots of mitotic figures. And important to note that CIN is confined to the epithelium. So cancer is when it breaches the basement membrane. So in CIN, it's confined to the epithelium and it becomes cervical cancer when it breaches the basement membrane. And so there are classifications. So CIN1 is low grade, which is mild dysplasia, and it's confined to the lower one side of the epithelium, and this usually regresses on its own, so it's not usually dangerous. It usually regresses. In a small minority of cases, it can become grade 2, but usually it regresses. And then CIN2 is high grade, so this is moderate dysplasia affecting the lower 2/3 of the epithelium. And then CIN3, which is high grade, is severe dysplasia extending to the upper 1/3 of the epithelium. And this is a carcinoma in situ. And the high-grade ones, the CIN2 and 3, are less likely to regress, and they are more likely to basically become cancer. And there's about 20% of them will progress to cancer if they're untreated. So it's not a very high amount. I mean, it's kind of high, but whereas with CIN1, most will regress and the cells will become normal. So, quick question: human papillomavirus causes cervical cancer, but what else can it cause? Head and neck genital warts, yes. It can cause genital warts. Head and neck cancer is usually caused by, it is caused by human. It is So different strains, yeah. So three strains here, so 16 and 18 and 31, 33 and 45 can cause head and neck cancer. And then strains, and do you know what strains it is that can cause genital warts? But other strains of human papillomavirus can cause genital warts. Yeah, I think it is 6 and 11. I have it later on, I just don't want to say it wrong. So, the screening program. So, one other thing I would say is make sure you learn the screening programs. So, learn the one for breast cancer and for cervical cancer, and learn why there isn't a screening program for prostate cancer, because it's the kind of thing that they could come up in a history. So, for screening programs, women between the age of 25 and 49 are screened every 3 years, and men from 50 to 64 they're screened every 5 years. And if you have HIV, you're screened every year, and that's just because you're much more high risk of getting cervical cancer. So this is, I think it changed last year or the year before, but now what happens is you take the smear, and then you test the smear for human papillomavirus. If the smear is positive, it's then tested. Cervical cytology is done for it, and the cytology is where you look for the changes, and the cytology is where you grade it as CNN1, CNN2, or CNN3. So what they used to do is test it straight away, do the serology straight away. But recently, basically, they found that if you don't have HPV, the chance of you getting cancer is like minute, like it's less than 0.5%. So, or I think it's even less than that. So basically, they've decided it's easier to screen the samples for HPV, and if you have HPV, then to look at the cytology rather than do the cytology first. So I think that guideline changed last year or the year before. And as Anish said, make sure you always ask about cervical screening in your histories. So ask, like, have they had their last smear? Was their smear normal? Have they ever had any abnormal smears? And then the vaccine program. So there's a vaccine that's now given which protects against 16 and 18. So it protects against cervical cancer, and then it does 6 and 11, which is what causes genital warts. And it's given to boys and girls at school. So you guys would have probably all had it at school, to go between the age of 13 and 12. And then 3 vaccines are needed, so it's 0, 2, and 6 months. So originally it was only given to girls. So when I was at school, I think only we got it. So actually only the girls might have it here. But now my little sister's at school, and the boys have also had it, because I decided that boys can pass it on, and also it can protect against head and neck cancer. So it's unlikely to stop the rate of cervical cancer, because obviously there are 3 other strains that can cause it, and uptake isn't global, but they're hoping that it will massively reduce the incidences. Okay, so the outcomes. This slide is going to look really confusing, but I hope if you look at it later on, it might make more sense. So you've had your cervical screening and they tested it for HPV and it's negative. That's fine. You go back into the routine pool, so in 3 years or 5 years, depending on your age. Now, it's positive. So if it's positive, HPV positive, cytology is done. If the cytology is negative, so it doesn't show any changes in cells, nothing, so the cells are all normal, you will get a repeat smear done in 12 months. So I'll test again for HPV, and it's probably still going to be positive, so then they'll do another cytology check and have a look at them. Or you can get a borderline or mild score, so that was a CNN1. And then you have a colposcopy within 6 weeks, or you repeat the smear in 6 months. So it's trust dependent. Some trusts will do the colposcopy and some will do another smear in 6 months. However, if it's severe or moderate, you need an urgent colposcopy within 2 weeks, so basically like a 2-week wait referral, and then you need to remove the area of CIN, basically, so you need to remove those cells. So what happens is you either do diathermy and chirocautery, so you like cut them out or burn them out, basically. Or you can do an excision, so you can do a cone biopsy, which is literally what it says on the tin, where you like take a cone and you like take a cone of skin basically and like scoop it out, and that basically takes the cells and then like takes the ones at the core. So this can cause cervical stenosis. So that can cause problems if the woman gets pregnant, because the cervix like scars and it can't actually open. It can't open at all, or it can't open very far when they go to give birth. Or you can use the Lutz procedure, which is basically where you get like a loop thing, and that loop like scoops out cells. And then once you've taken away the cells, the woman has a repeat smear test in 6 months to test for a cure. And then if it's positive, you do the colposcopy again. And if it's negative, then you do, then she goes back into the routine screening. And the last category is inadequate. So sometimes you get inadequate smears, and this might be because there's been blood in the smear, or just because you haven't got enough cells. So if it's inadequate, you do it again in 3 months. And if you have 3 inadequate smears, you just refer for a colposcopy. Does that make sense to everyone? I'll give Anisha slides after I've done it, and then you can all have a look at them. But I found this like really confusing to remember. So hopefully if you look at that again, it might make more sense. But are there any questions about that? Okay, going on to the next slide. So this is a 28-year-old woman who's had her second cervical screening test a few weeks ago. The results show a moderate dysplasia, who's come to see you, and she has some questions. So does she need any further investigations or treatment, and will she need more screening tests in the future? So does anyone want to pop their answers in the chat? After this, we've got a few more slides and we're nearly done. Anyone got any ideas? So because she's got moderate dysplasia CNM1, you're right, she does need a colposcopy. So the investigations need to refer her for an urgent colposcopy in 2 weeks. I should probably explain what a colposcopy was. So basically, it's like you do. So you can do it with a speculum, or you can do it without a speculum. But basically, you put a camera through the vagina and you look at the cervix effectively. So it doesn't go as far as a hysteroscopy, which goes through the cervix into the uterus. So it just goes into the vagina to look at the cervix. And you can do it with a speculum because obviously that makes it a bit easier. But you can also do it without, because the idea is that without a speculum, it's less painful. So you refer for an urgent colposcopy, that is correct, and then management, she will need the abnormal cells removing. So she either needs ablation or excision, basically. And what happens will depend on like how the area of abnormal cells, like how big it is, how easy it looks to remove, the margins of it, and what the clinician is like preferred to do. And then further screening, she'll need to test for a cure in 6 months, and if it's negative, she can return to the normal screening program, and if it's positive, she'll need a follow-up colposcopy. Her cervical cancer is basically a progression from CNN. So what happens is the epithelial basement membrane has now been breached, and it's most commonly squamous cell carcinoma, but it can be adenocarcinoma or a mixed tumour. So symptoms, you get abnormal vaginal discharge, you can get postcoital bleeding, intermenstrual bleeding, and then postmenopausal bleeding. You can also get like pelvic and back pain, and then painful sex. And then the speculum will just show like cervical discoloration or an ulcer or like a weird looking patch on it, and also it will probably contact bleed. And then you refer them for a colposcopy and biopsy, which will show there's abnormal cells, and then they will they'll have FIG staging. So the management, if it's microinvasion, so stage 1A1, you just basically do a cone biopsy. So cone biopsy excision, which is what we talked about for CIN. So basically a little cone goes in, you take away the cells, and then you can do lymphadenectomy. And if the margins are unclear, then you might do a hysterectomy, or you can do some chemoradiation afterwards. Then in early disease, you can do a radical hysterectomy and pelvic lymphadenopathy, and then chemoradiation. And if you want fertility preservation wanted, you do a radical trachelectomy and lymphadenopathy. Basically, what you do is you take out like the vagina and the cervix, and you take out the cervix and like the bottom of the uterus and insert the uterus. The woman can then get pregnant, but she has to have a C-section, effectively. And they don't really like to do it because obviously you've left in the uterus, which is connected to the cervix, so the cancer could have spread. But you can do it if the woman wants children, because cervical cancer generally affects younger people than like endometrial cancer. So lots of women who will get it will still be premenopausal and therefore may want children. If it's advanced, you do chemo and radiation, and if it's mets or recurrent, you also do chemo or immunotherapy. Okay, So before we finish, quickly, if I do a smear station, so have you guys been taught how to do a smear? The ones of you who have had your women's health blocks. So you could get a station. I don't know Anish, but they emphasize this quite a lot for us as like a possible kind of OSCE station. So either doing the smear or talking to the woman afterwards about the smear. So basically, you want to do the smear and afterwards you want to talk to them about how to get the results, what happens if the results are abnormal, what happens if they're normal, and go through it with them. Some important things to say is if it's normal that you go back to routine screening in 3 or 5 years time. If it's inadequate, so there's not enough cells, or that you've got an infection, or you can't interpret the results, you come back in 3 months. And if it's abnormal, abnormal cells have been found, and you will be referred basically for preferred for another step like treatment, but it depends how abnormal the cells are as to what happens. So I will probably make some OSCEs, but I will make some OSCE stations for you guys after my finals. But I would look over cervical screening and smear testing, because I think it's quite an easy thing to come up, to like talk to someone about, and talk to them about like have they got cancer? No, it's not cancer. It's a step before cancer. It's where we have some abnormal cells, and it's really good that we treat it now because we can help prevent it from becoming cancer. Yeah. Has anyone got any questions on that or anything else? Or Anish, have you got anything to say?
No.
Anything about OSCEs to say? Have you guys got any questions about OSCEs? Anish, can you post the feedback link? Should have it on hand.
Sorry.
I don't have it. Yeah, has anyone got any questions? Has anyone got any OSCE stations they want me to go through in terms of ONG? Or any questions about tumours or anything like that? And if you could please fill in the feedback form, that's really helpful for us.
Yeah, that's a classic AT.
Yeah. So I think I've said this before. The year before us, yeah, it is a common station. I think the year before us, their ABCD station was like postpartum hemorrhage. So, because I guess it's an easier one to do in the sense that you don't need any real obstetric knowledge to be able to do it. Or not obstetric. You don't need like to know how to like birth the baby or anything because the baby's been birthed. Yeah, that is I think the most common one to come up. Other ones that like could sort of come up are like history taking from women, like sexual history, which kind of links in with GUM, and like STI screening, which links in with GUM. Then cervical cancer screening, and like, I guess breaking bad news, like cancer stations, or like reporting back cytology results is something that could come up. I don't really know what else in terms of ONG. Obstetrics, like pregnant abdomen exam, like bimanual speculum, obviously. You could, I know this is more PEDSy, but like a Down syndrome diagnosis, or talking to women about how to get tested for things and like genetic testing and that kind of thing. That's obviously more PEDS related. Then, yeah, I'll have a think. It's difficult because we didn't do our OSCE, so I don't know what they would have given to us. So apparently, Lizzie, they do have actual children in the OSCE. Like apparently they're like consultants' kids, and I heard that usually they're well behaved, but sometimes they can do what they want. But yeah, usually. Anish, did you hear that they're actual children?
Yeah,
I don't know about
this.
I don't know if yes, yeah, because we've been taught like our OSCE is obviously in a few weeks, and we're not having any patients; they're all actors. So I don't know if for you guys they would do the same thing, like no patients or actors. So I don't know if you could do a kid acting for that. Like, seems a bit more difficult.
Also, kids are like infection risk.
They are, yeah. I'm not sure how you get them to stick to the rules. And yeah, Paulina, for like the like PEDS or ONG kind of mixed station, you could do things like testing. So you could do, they can talk about like chronic villus sampling and amniocentesis and like the risk factors of both of those. You can talk about if you've missed the window for the combined testing. So now you can do like the triple test or the quadruple test where you look for like inhibin A or something, and then P para like beta HCG and something else which I can't remember. They could like, ask about those. Yeah, I really can't think of any other ONG stations, but there definitely should be some.
ONG is quite likely to be like an emergency thing, I think.
Yeah, it'll be an emergency, and then it'll probably be a pregnant abdomen or a speculum.
It can also be a female catheter.
Or a female catheter. And then it will probably be some history related stuff. So like history of a patient with preeclampsia or that kind of thing. I think is what's most likely to come up.